So it's my pleasure to introduce Dr. Joe Parks. Dr. Parks went to undergrad and did medical school at the University of Michigan. He did his psychiatry residency at Boston University and then was a fellow in emergency psychiatry in Cincinnati. Was the nation's first emergency psychiatry fellow, interestingly. Dr. Parks has held nearly every mental health and behavioral health leadership position in the state, including directorship of the Missouri Institute for Mental Health, medical director of the Missouri Department of Mental Health, and he's been president of the Mental Health Council of National Association of State Mental Health Directors. He's been division director of comprehensive psych services for the Missouri Department of Mental Health, and I could go on and on. Dr. Parks still practices psychiatry at the Family Health Center, which is the federally qualified health center here in Columbia. His current titles include Director of the Missouri Health Net, Missouri's Medicaid authority. So this is kind of a new role for him, and we're delighted to have him in it. He's also Distinguished Research Professor of Science at the University of Missouri St. Louis and Clinical Professor of Psychiatry at the University of Missouri in Columbia. So please join me in welcoming Dr. Joe Parks.
Thank you, Karen, and I want to thank everybody for coming out this morning. In particular, I want to thank you on behalf of Governor Nixon for everything you do every day to take care of people's health here in Missouri. Your efforts are greatly appreciated. Y'all had a really great lineup yesterday. You heard some presentations about population health. You heard some presentations about community navigators. And I'm going to give an example of implementation of those two principles here in Missouri in our Health Homes initiative, of which University is a part. You're one of our largest primary care sites doing this project. So I'm going to start out talking from my own background as a psychiatrist, as somebody that's spent his career taking care of people with serious mental illness. And I want to start out by telling you about a patient I had for a number of years at Family Health Center. Her name was Vicki. And when I met Vicki, she was in her mid-30s, about late 30s, and she was homeless, and she was using crack and drinking a lot, and she was living on the streets and getting victimized by all kinds of men. And she would call me up at odd hours saying she was suicidal and she was agitated and she was thinking of killing herself. And she worked hard to get better. It took about a year, maybe 6 months, 9 months, and a couple rounds of treatment to get her off her crack and methamphetamine addiction. About another 12 months after that to get her sober most of the time. It became clear she had bipolar disorder. We did some medication treatment of that. It became clear she had a lot of PTSD from extensive sexual and physical abuse as a child, and that took about several more years. So after working with Vicki for about 8 years or so, she had gotten to a place where she was she was sober all the time. She was taking some part-time college courses, had her own apartment. And she really had gotten her mental health and was functional in the community, had a network of friends. And that's when she dropped dead of a asthma-exacerbated clot that was too large to get through her inferior vena cava umbrella. And she died of vascular occlusion. What had happened to Vicki is she had continued smoking 3 packs a day. She had gained about 150 pounds. She had bad asthma, and whenever she would get her asthma attacks, primary care would have to increase her prednisone, which would make her mood much more unstable and exacerbate her psychosis. And we were just chasing one thing after another. So in mental health, that's what you call winning all the battles and losing the war. Because the lesson here, we're about recovery from serious mental illness, and people don't recover after they drop dead of a chronic medical condition, which is a major problem in my business. Life expectancy of someone in the U.S. with no mental disorder is in your late 70s. Of any mental disorder in the general population, about 10, 12 years less, mid-60s. Somebody in the public mental health sector, in the Department of Mental Health, where I used to work, getting Medicaid, going to federally qualified health center, those kind of public settings, mid-50s. Average age of death in the mid-50s. This is sub-Saharan Africa average age of death. This is less than the life expectancy of someone newly diagnosed with HIV. This is an appalling epidemic. This is a disparities population that largely gets ignored. This is also the population that, by and large, drives the high utilization in the American health system. What had killed Vicki was metabolic syndrome. I want to show the difference in rates here. The CATIE study was a study of people with schizophrenia. It was designed to compare antipsychotic efficacy. Is this new one better than that new one? The NHANES, as most of you know, is a CDC survey of the whole population that's done every 3 to 5 years. So this compares the rates of these chronic risk factors in people with schizophrenia who go to academic clinics that are able to do multi-center national research, clinics that presumably have their act together, to the general population. Metabolic syndrome is having 3 out of the 5 conditions: being overweight, having dyslipidemia, having low levels of protective cholesterol, having high blood pressure, or being pre-diabetic or diabetic. Having metabolic syndrome gives you the same risk of having a heart attack in the next 10 years as someone who has already had a heart attack. The same risk as someone who's already had a heart attack if you have 3 out of 5. So for the general population, men, about 1 in 5 have metabolic, 3 out of 5. If they have schizophrenia, it's 1 in 3. For women, it goes from 1 in 4 to 50-50. You should assume that a woman with schizophrenia has metabolic syndrome until proven otherwise. And what's most likely to kill her is not suicide, is not an accident while she's psychotic. It's cardiovascular disease, diabetes, or respiratory illness. Look at the rates of poor control of dyslipidemia, 50%. The rates of hypertension, almost 50%. The rates of diabetes running 20 to 15%. Actually, the diabetes isn't worse in the men. And surprisingly, when they looked at the treatment of these people going to university clinics that could do research, of the 60% who had dyslipidemia, 88% were not being treated. Of the almost 50% that had hypertension, 62% were not being treated. And of the 15 to 20% who had diabetes, 30% were not being treated. In university clinics that can do multi-center research, but apparently cannot identify and treat hypertension. This is shameful, this is appalling, and this is what we're trying to change. This is what we have changed with our Health Home Initiative. The causes of the excess mortality, why they die in their mid-50s, smoking, about a 50-60% rate of smoking among people with substance abuse and serious mental illness. Obesity, 2 to 3 times more likely to be obese. Inactivity. Polypharmacy, taking way too many medications, often due to medication non-adherence. You know, not taking medications as directed is a major cause of taking too many medications. Because if you only take your antihypertensive half the time and you're embarrassed and you don't want to tell your doctor you're only taking it half the time, then you're likely to get a second one. And now you have 2 you can take half the time, and you're well on your way to a third. It's the same way with antidepressants, with most others. If you think before you increase meds, you should always make sure they're taking the darn things. They only work if you put them in your mouth. This is a real shortcoming of the pharmaceutical industry. They need to develop pills that work if you don't take them. Low-level joke. Very low level. So this all adds up to a lot of expense also. You know, I went to my first national meeting of Medicaid directors last May. We get together twice a year, the 54 of us, the states, the territories, and the district. And this time we went around the room and we're each asked to say what we most wanted to discuss with our colleagues. What was the issue that we most needed input, that we felt we had to do something about? I was towards the end of the list. I was about number 40 or 42 to stand up. But of the people there, and I was the only psychiatrist, the only mental health guy, 2/3 of the Medicaid directors said what they most wanted to discuss was behavioral health. 2/3. Why would they say that? Why does Medicaid across the nation want to talk about behavioral health? Well, a lot of it's because that's where the money is. For people with no mental disorder, in the private sector, the costs are about $370 per person per month, per member per month. That's how us payers talk about costs. In Medicare, whether it's disabled or elderly, it's just shy of $600. In Medicaid, which is a mixed population again of the pregnant women and children, the cheap ones, and the expensive ones, the elderly and disabled. It comes a little under $400. For the same populations, if they have a mental disorder, substance abuse, or mental illness, the costs are about 3 times as much. Now you know why all the payers want to talk about behavioral health, because that drives their spend. And much of that spending is the medical spend, not the behavioral health spend. Here's some numbers from New York in annual numbers. New York's a very expensive place to get medical care. Our numbers would not be near this crazy high. Our pattern will be the same. People with a mental health disorder cost about $21,000 a year in New York Medicaid. Substance use disorder about the same. If they have no, they're $5,000 cheaper on their medical alone. And their behavioral costs are about equivalent to their increased medical costs. If you're looking at high utilizers, if you're looking about people getting a lot of care, you're talking about people with behavioral health conditions by and large. So our strategy in Health Homes was bidirectional behavioral health integration. We wanted behavioral health care in the primary care settings, and we wanted attention to primary care, chronic illness in the mental health settings. We do a lot of case coordination and facilitation of health care. We use community health navigators. We call them community mental health workers. They've been on the mental health side for a while. They just weren't attending to chronic medical illness. We've added primary care nurse managers to the CMHCs and primary care nurse managers to the primary care settings also. It's a bigger change in the CMHCs. They didn't have a lot of primary care stuff. Now, how many of you have had cultural training? Come on, you're university people. I know we make you do this all. Yeah, exactly. Be honest. And it was about ethnicity. It was about race. It was about religion, right? I'm here to tell you that there are professional cultures that impact what you do day to day just as much as the ethnic cultures. What is your professional culture? It is what your profession has taught you to do when you don't know what else to do. Every profession teaches a default solution to when you're anxious and you must do something or you can't just sit there. So if you're a psychologist and you get anxious, you're trained that if you measure things enough, something will get better for some reason. That is their default solution. The psychologists are laughing. They know this was hammered into them. If you're a social worker, you've been trained to affiliate. If you don't know what else to do, you'll form groups and discuss it with each other under the misperception that understanding might make things go better. Sometimes it actually does. Isn't that delightful? If you're a physician and you don't know what else to do, you'll make a decision regardless of how little information you have. That is what we're trained and expected to do. And you would be deeply disappointed if we didn't do that. If you're a nurse and you don't know what to do, you get together with any other nurses on hand, you form a committee, you write a policy, you create a monitoring form, and you nag the snot out of everybody till they follow it. If you want a new organization, if you want a new program, get yourself some nurses. You don't need the psychologist to measure it until later when it's up and running, and there's no decisions to make till you got the program. Nurses were key. Nurses were transformational in the organizations. We're doing disease management. We're doing diabetic education, weight reduction, increased physical activity, asthma education, using the same platforms we used to do for the mental health approaches of increasing your interpersonal relationships, hygiene, shopping, same small group educational things. You know, the primary care health homes, 15% of the people have diabetes. In the CMHC health homes, 30% of the people have diabetes. There's twice as many diabetics in community mental health centers as there are in primary care clinics. If you want to do diabetic education, where do you go? Where do you go? We do a lot of preventive screening. Everybody gets screened for metabolic syndrome, and some integration initiatives. We use a lot of health information technology. For primary care, we're aggregating EMR data extracts to run our numbers. For the CMHCs, we're using primarily claims-based. We take the claims to see what your diagnosis is, to see what medications you've been filling. The cool thing about a claim, if the EMR can only tell me what I wrote. The claim tells me what the patient filled. They don't fill everything I write. You know. There's a difference between the two. You know, EMRs have a ton of detail in them, but you only get what the organization puts that uses it or any other organizations participating, and most practices are not participating in information exchanges, and about half practices still don't have EMRs. Claims don't give you as much detail, but you get everything. If you think about it, your payer knows more about your care than any of your individual physicians. And they know about your care before most of your physicians know. If you get admitted to the hospital, I guarantee you that your insurer knows within 24 hours you're in the hospital, and your primary care doctor doesn't know till later, most probably. I know you have initial alerts in your power chart, and you get that if they're on power chart, but if they go to Boone, you're out of luck. Yeah. So the power of claims is they're broad, and it's dumb that every payer doesn't take those claims and insist that the providers look at them. They won't give them to you now, most of them. Aetna won't give them to you, Covington won't give them to you. At MoHealthNet, we put the claims out on a website. Anybody can look at them. In the health homes, if they don't look at them, we stop paying them. Because when you open a website, you can tell who looked at it when for what. That's how you get care coordination done. So the health home operation is not really a benefit or support. It's a different way of doing business. It is population health management. It is data-driven care. It's about holding these practices, both primary care and CMHC, accountable to be the public health entity for the clinical population they serve, and not just doing individual complaint-driven care. If you think about it, our major business model, our major care delivery model, is we depend on the patient to figure out when they're sick enough to ask for help, what help they ought to ask for, and who they ought to go to ask for it. Now, these are people certainly that in general have no training in healthcare, that don't know our delivery systems, and a good portion of them, especially those with mental illness, have deficits of concentration, memory, perseverance on task, organizational skills. Yet they often have 10 different illnesses on 16 different medications, and they're the person we're depending on to figure out who needs what care when? How are we ever going to succeed with that model? So the change in health homes is to use data to pick out who needs care, and to not only go after fixing one individual entirely, but to looking across the population and at key conditions, high volume care gaps. Population management is about underutilization. Managed care is about overutilization. Managed care says we're getting too much of the expensive stuff, let's tell them to stop doing that. Well, it's hard to stop doing things if you don't know what else to do. I could tell you to stop thinking of elephants, but you have to have something else to think about. Health homes is about telling them what else to think about. Health homes focuses on, and population management focuses on underutilization, and by and large lets overutilization take care of itself under the theory that if we get enough of what you really need, you won't be running to the ER and into the hospital. So instead of being an individual practitioner, it's an integrated team with behavioral health and primary care, whether that's based in a community mental health center or in a primary care clinic. It's continuous care by monitoring for care gaps. It does care management and increases access and focuses on underutilization instead of overutilization. And it is data-driven. We do not wait for the patient to figure out what they need. We have two different populations. We have our primary care population. To be eligible in primary care, you have diabetes or you have any two of the following: a respiratory illness, COPD or asthma, cardiovascular disease, being simply overweight, using tobacco, being developmentally disabled. We added them in because they're fragile, they have complicated needs. If you're in a CMHC, you have a serious mental illness or any other behavioral disorder plus one of the chronic medical illnesses you see listed. The eligibility criteria are very broad. One thing we did differently from many other states doing this initiative is we didn't enroll everybody that was eligible. We only enrolled the high utilizers. So if you're in a CMHC, we enrolled you if you cost more than $10,000 in the previous year and you're not terminally ill. In primary care, we enrolled you if you cost more than about $4,000 in the previous year and you're not chronically ill. So this is a combination of what on the primary care side would be called a person-centered medical home and the Candom hotspot approach. It is a medical home for high utilizers, not for everybody, not for everybody. We are statewide. All the FQHCs participate, and a number of hospitals with outpatient clinics, including University Hospital here, participate. About 90 to 100 primary care sites statewide, about 16,000 people. On the community mental health center side, all 28 community mental health centers participate, 120 different clinical sites, about 19,000 people. This is not a demonstration project. This is an ongoing operation. It's not regional. It's not temporary. This is how these organizations do business now when they work with MoHealthNet. We gave them all new staff. Everybody got a healthcare home director. We expect them to change how they do business, how they deliver care. So you need an administrator to nag the rest of the executive team to remind the CEO that he or she promised to do this, and they got to change their evil ways. Well, it's hard to change us CEOs. You know, we're very recalcitrant. I mean, Dr. Edison and I hardly ever are willing to change anything, are we? We need staff to remind us that we promised to do that. Oversees the daily operation, makes sure the staff are using the health information technology tools, that the alerts are being acted on, developing memorandums of understanding with practices and hospitals around town, just making all the pieces fit together. Both primary care and CMHCs get a nurse care manager. They have a caseload of about 250 people each. The nurse care manager does an annual risk assessment, is really the backbone of the operation, meets with the rest of the care team, decides who will act on which care gaps. Sometimes they act, sometimes they delegate it to the community support worker or other people on the team. They do face-to-face education with the patient also. In the CMHCs, they all got a primary care physician consultant. We didn't think we should be telling mental health organizations to manage a bunch of primary care without having a primary care doc somewhere in the organization. They're not there to deliver primary care. They're there to advise on individual cases, to help the team select what care gaps they want to go after, to be the strategy and the consultant. This is kind of interesting if you're in primary care. They usually use consultants. They don't get to be a consultant. It's kind of a new role, you know. Shoes on the other foot now. Also, it buys relationship with primary care around town. We all know our buddies. And if we have our own primary care doc, they know the other primary care docs in town, so that we can have our buddy call them up instead of a stranger call them up, you know, because most of healthcare gets done by a personal relationship. Most of any business gets done that way. Another trend you're seeing nationally is care management not occurring anonymously from a remote site or a phone bank or a letter, but being pushed down to the local providers. And if you're going to be an effective provider, if you're going to be a competitive provider, you're going to have to figure out how to do care management, because the payers are going to want to download that to you. And it's more effective because you're more likely to change in response to a personal relationship with someone you know than an anonymous prompt from a letter or a phone call from a stranger that you most likely will never hear from again. The primary care sites all got a behavioral health consultant, usually either a social worker or a psychologist, who helps screen for and also do direct but brief interventions on substance abuse and mental illness, and also the behavioral aspects of chronic illness. Behavioral consultant is not just about anxiety, depression, and alcohol. They're also about the changes a person must do when they're newly diagnosed with diabetes. The acute stress reaction or general behavioral reaction somebody has when they learn they have cancer. All those behavioral sequelae. Medication non-adherence. Taking your antihypertensive is a behavioral issue. Medication adherence is a behavioral issue. Behavioral health consultant assists the primary care team with all of that. On the CMHCs, we still have the rest of the team that's always been around, the psychiatrists, the psychosocial rehab workers, the community support workers. And the model is to do bidirectional integration. In primary care, they have behavioral health consultants. They do expert screening for excessive drinking or risky drug use. Not necessarily alcoholism, but you're just getting up there and you need to be told, hey, not everybody has a six-pack every night. You know, that's only 5%. So it's web-based, screening for depression, PHQ-2 screening. 6 of the 20 quality performance metrics on primary care side are behavioral health measures. 4 of the 8 medication adherence measures are behavioral health measures in primary care. And they get benchmarked and feedback on their behavioral health, their psychiatric medication prescribing. On the community mental health center side, they all get primary care consultants. They have primary care nurse care managers. Everybody gets an annual metabolic screening. Everybody in the CMHC health home is checked for their LDL, their cholesterol, their hemoglobin A1C, their blood pressure at least annually. 10 of the 20 performance measures in the CMHCs are medical. They're accountable for HEDIS scores on hypertension, diabetes, cardiovascular disease, and 4 of the 8 medication adherence measures are medical. We think that the entity that should manage you is whoever you see most frequently. Whatever provider you see most often is best suited to be your care manager because you have more opportunity to interact with them than anybody else. So the principles: to have one team, one plan, not two separate teams. We don't have a separate care management plan and then the treatment plan, or a separate mental health plan and then the care management plan. And at the CMHC side, we're by and large, about a third of them do primary care, but most people do not get their primary care at the community mental health centers. Even if that community mental health center does primary care, it is a wraparound. They provide these supports to primary care practices that do not have the data, that do not have the staff to do this. So they'll be making sure that the person gets in to see their primary care doctor just like they get in, make sure they see their psychiatrist. They'll be doing pill counts on their antihypertensive just like they do it on their antipsychotic. They'll be following up with them after they're discharged from a diabetic admission just like they follow up with them after a suicide attempt. It's the same supports that CMHCs have always been doing for the psychiatrists, they're now doing for primary care and medical specialists also. The 6 required services are care management, looking for care gaps, care coordination, managing transitions of care, inpatient to outpatient, preventive care and health promotion, individual and family support. Do you have a social network? Do you have a place to live? And referral to services. Are you getting your heating voucher? Do you have your transportation covered? Not medical referrals, referrals to those social determinants of health that at the end of the day make a bigger impact than the healthcare services we deliver. So what do I mean by care management? Care management consists of identifying and targeting high-risk individuals, looking for adherence and treatment gaps. I'll give you an example. The way we do it on the CMHC side, again, is getting the diagnoses from the claims. We make the CMHCs send in those metabolic screening values, so I can look at your claim and see if you have diabetes, and I have your hemoglobin A1C, so I can see if you're under control or not, and I can make a HEDIS indicator. I know what percentage of people with diabetes have a hemoglobin A1C under 8%. On the primary care side, we do it out of electronic medical record data extracts in a data warehouse, a disease registry. So you look for the care gaps, you sort out to-do lists. Here's an example of how we would do it. We would look for everybody with a diagnosis of asthma, then in the pharmacy file would look to see who is on an inhaled corticosteroid. If they're not on an inhaled corticosteroid, they'd go on the list for the nurse care manager to figure out who's going to get them to primary care to say, hey, should Joe get an inhaled corticosteroid for his asthma? Of those that are on an inhaled corticosteroid, would look to see how often they're filling that script. If they're filling it less than 8 out of 12 months, would say, hey, you're not taking it all the time. Why not? Do you not like it? Can you not afford it? Did you just forget? Because you're supposed to inhale your corticosteroid every day. It's not a rescue inhaler. Using this, and they would generate to-do lists. Here's your 20 patients that aren't on one that maybe should be on one. That's an individual decision, not for sure, but it's a question to go to primary care and ask. And then here's another 10 that are on one but only fill it half the time. Doing this, we've been able to drive the percentage of people without an inhaled corticosteroid down by 50%. And the fascinating thing is when we ran the numbers, putting them on an inhaled corticosteroid decreased their psych meds by an average of 1. Why would inhaling a corticosteroid cause you to take fewer psych meds? But anxious, yes, because you're overusing your Alliapent rescue inhaler, of which a third of people use it wrong and swallow it at the back of their throat. You huff on that pup more than about 6 times a day, and you're going to feel jittery, shaky, nervous, and you're not going to sleep. And you're going to come to your psychiatrist wanting some Xanax during the day and some Ambien at night, which makes it much easier to fall down in the bathroom at night. It's all connected. That's why it's important to integrate this stuff. That's why you can't sub out separate parts of care management. Care coordination, making sure that the multiple providers know what they're doing, what each other's doing. One of the major duties the health home has is to give information to providers that are not in the health home. The electronic tool allows them to print off a summary of all care for the last 3 years. If somebody's going to a new doctor, we expect that new doctor to get that summary. So if you're in a health home, you get a new patient, you should be offered a report of their prior diagnoses, treatment visits, medications. Think how much easier that makes it to do your initial assessment, how much time that saves, how much better accuracy than expecting each other to remember it. I want to say a word about HIPAA, and I want to say a word about how most organizations train on HIPAA. Most organizations are delusional, are paranoid delusional when it comes to sharing health information. They are absolutely out of their minds. The federal reg explicitly says, and Missouri law allows you to share information absent consent, even over the patient's objection. They can say, I don't want you to share, and you can still share as long as you don't have adopted a policy saying that you won't do that. That's what the federal reg says. That, I swear to God, is what Missouri law says. I swear to God. How many of you have practiced at least 10 years? How many of you have practiced 10 to 20 years? 20 to 30 years? Anybody at 40? Yeah. Okay, so we got probably in the room about 1,000 years of practice. How many of you personally know or have personally spoken to at least just one person who has had a HIPAA fine for an individual patient care episode? I do this survey about once a week for the last 5 years. I've not seen a hand yet. This is paranoid delusional fear. This is nuts. And most of the people training on this stuff have not actually read the reg. If you say, well, tell me where it says I can't say it because it says here, I can do that. It's crazy. So here's some of the, I won't do that. I'm going to show you the outcomes now. First, I'll show you a little about our population. Here's the difference in percentage of chronic illnesses of people in our at baseline. The health homes have about 1 in 4 people with asthma or respiratory illness compared to 15% of the general population. Diabetics at 26% compared to 8% of the general population. Hypertension only slightly higher, 5% bump. Obesity somewhat higher, but look at extreme obesity. The people in the health homes have much higher rates of extreme obesity. Weight's a big deal. And a lot more substance use disorder. Here's how we're doing. The baseline year is 2011. We started January of 2012. The CMHCs, the average blood pressures were running about the population average, because I'm talking population management, so I'm going to show you a population average to start with, a la Framingham. A la Framingham. We're talking about looking at our clinic as a community. Average pressures were 145 over 90. A year later, population average pressure was 133 over 83. 2 years later, 131 over 82. Primary care, they started out more hypertensive, didn't drop quite as much, but in each case we got a 6-point drop. Framingham study tells us a 6-point drop in blood pressure over 10 years leads to a 16% reduction in cardiovascular disease, a 42% reduction in stroke. Small changes, big difference. Population style. This is what I mean by healthcare providers doing population health management and not just one-off care. We are a cottage industry, and we got to cut that out. We got to act like a real industry. LDL levels over time. One thing I don't like about HEDIS indicators is, why should I only care about your LDL after you have cardiovascular disease or diabetes? An elevated LDL is a leading indicator, not a trailing indicator. Why would I only look at your LDL after you get diabetes? That's dumb as dirt. We look at everybody's LDL. It is. It's just, we should admit when we're being stupid. Initially, our LDLs in the CMHCs were 30 points over that nice 100 baseline. A year later, got them down by 15. Second year, down to 111. The primary care got a nice 9-point drop in the first year, down another 4 points in the next year. These are better than 10% drops that will yield better than a 30% reduction in cardiovascular disease. Hemoglobin A1C, in the CMHCs, we get it on everybody, not necessarily in primary care. So in primary care, this is more a diabetic population. But look at the difference. In the CMHCs, I'm getting them on everybody. In primary care, I'm only getting them on the diabetics, yet I start out with a higher baseline. Sicker people, more people, 30% and higher hemoglobin A1Cs. But if you focus on it, 1-point drop in the first year, down to 9%, about another half-point drop in the next year. Some nice reductions on primary care side also, total of about 0.75% drop. 1% drop, 21% decrease in diabetes-related death, 14% reduction in heart attack, 31% reduction in renal failure, blindness, and peripheral neuropathy. Here's the HEDIS indicators if you want to see them for diabetes. This is just on the CMHC side. At our baseline, only about 22% of people had a measured LDL under control, 27% for blood pressure, 18% for hemoglobin A1C. You can see coming up to January of 14, that we have exceeded the Healthy Person 2020 goals. I have no idea why that's only 36%. Why the heck would that be our national goal? Blood pressure, we're above the national goal, and hemoglobin A1C, we're almost at it. Seeing similar progress on hypertension and cardiovascular disease. Again, I'm less than enthused with HEDIS indicators, but they are the industry standard, so we show them and present them. They are not true population measures, and I don't think they're the way to go in the future. Where we're not making any advances is on getting people skinnier. Body mass index is not budged. Tobacco use is not budged. We are getting metabolic screening. We're now up to 85% metabolic screening on the CMHC site. 85% of our people get checked annually. The national average is around 20%. I'm very proud of that. Medication adherence, we've been working on since 2004. So we were already up around 80%, which is generally considered adherent. We've gotten a little bump, but we had pretty much eaten our lunch there and pushed those numbers up. Hospital follow-up. We expect people to get followed up within 72 hours in the first month and get a medication reconciliation by the nurse. When we started, it was about 30% getting followed up with a reconciliation at 72 hours. We're now up to about 2/3. If you go out to 7 days, we're about at 90%. We have two cool data feeds. Every time somebody gets admitted to Mo Health Net, you have to call us up and say, Joe's in the hospital with pneumonia, and we say you get 3 days, click, and hang up. We take that initial authorization of stay feed, it gets automatically dumped to a program that sorts it out by health home and sends an automated email out overnight to the nurse care managers with a list of everybody that just got admitted. So it's next day admission, notice of admissions. We're about to start with next day notice of ER visits. I hope to do that next month. How many of you remember the anthrax scare after 9/11? Well, it turns out that the feds at that point made all the hospitals, yours included, start sending a real-time data feed to the Department of Health in every state so they could do syndromic surveillance for the next epidemic. That's how they're tracking Ebola. They get a little snippet of information anytime any of us go to the ER. That means the Department of Health knows when everybody's in the ER within an hour or two. So we're getting their database, and we'll be pushing that. So every morning the health homes will get an email saying, here's everybody that went to the ER. Why don't all payers do this? It's in their interest. They'd save more money. Why do they expect you to deliver care without telling you a darn thing about what's going on? It's criminal. It really is criminal. As a result of our efforts, hospitalizations are down for primary care, about 24%. 24% of people had at least one hospitalization in the baseline year before we started. Now it's down to about 16% in the CMHC side. Again, they're sicker. They had more hospitalizations to begin with, a little over 1/3. Now down to just under 1/4. Nice reductions. We've had more success with hospitalization than we have had with ER. It's been harder to deflect ER visits. Here's the primary care results, some decrease in ER. People like ERs. They're a rational choice. If I have a cardiac issue and I go to primary care, they're likely to send me to a cardiologist and schedule me for 2 procedures, and it'll take me 3 visits and 4 weeks to get it all done. If I go to the ER, I can get those 2 procedures done and see the cardiologist all in one afternoon. People would like to have their care like we go to Walmart, go whenever we want and get whatever we want. And we haven't figured out how to deliver that yet. I can't really beat up on the patients too much because it's a pretty rational desire and a pretty reasonable desire. We really set it up the way we do for our administrative convenience, not to really get them what we can get them at the moment they're ripe to take something from us. Dr. Edison asked me to also talk about our outreach program, the DM 3700 project. I've shown how well we do with people that are already in the care of the community mental health centers. A year prior to Health Homes, in 2011, we started a project where we analyzed the Medicaid tapes every 120 days for anybody that has a serious mental illness that's not engaged in a community mental health center and costs more than $20,000 a year. More than $20,000. I don't have my fiscal outcomes here. I dropped my fiscal. Dang. Okay, so the fiscal outcomes, I will report them to you. These interventions, these primary care practices get $60 per member per month. The CMHCs get $80 per member per month. Both are saving in excess of costs. The CMHCs are saving about $72 per member per month above the additional $80 they cost, all money in, all Medicaid spending in. Primary care is saving about $30 in addition to the $60 it costs. Both of them, CMHCs are saving about 15 million, primary care is saving about 7 million for the state annually. So why would CMHCs beat out primary care? They have somewhat better clinical outcomes and bigger cost savings. 2 reasons. One, the people were sicker and more expensive to begin with. You can't improve unless you're in a hole to begin with. Second, the CMHCs have their community mental health workers. They have bachelor level people that go around the community that were retrained on how to talk about asthma, hypertension, and to do these various care management tasks. So the nurse care manager has people that do home visits, community health navigators, if you will. We have not been able yet to resource primary care for community health navigators in the same way, and it makes a difference. It turns out what works here, what's different, is first of all data-driven, using data to figure out who I'm going to touch when. But the other part is a personal relationship. We all change in response to a personal relationship. So what is my unit cost for that personal relationship, and what is the dose frequency curve? When primary care does a patient interaction, it's usually by an RN. It shouldn't have to be an RN. Y'all should use more LPNs, cheaper unit cost. And it's usually in the clinic, and it's usually 15 to 20 minutes once every month or two. The CMHCs are sending in a bachelor level person who's targeted by the nurse and prompted by the nurse of what to talk about, but they are seeing somebody a couple times a month for a couple hours each time. It is a dose frequency curve of personal interaction that's targeted by data. That's what makes this stuff work. So DM3700, in this one we identified people with serious mental illness who were not in CMHC care, who were not terminally ill, and who cost more than $20,000. The old model is, again, we wait for the person to call us out. The new model is we go out and knock on doors. The CMHCs get a list of people around town and they seek them out. The best way to find somebody is to go to their pharmacy, because the pharmacy updates their address every month. Every time you go to the pharmacy, is this address correct? Your pharmacist knows where you are. So here's our old method. We have the patients wait in line. We give them an appointment a couple weeks from now and hope they still care enough to show up. This is why we get do not show rates. Here's our new model. We go looking for them. We go looking for them. $20,000 minimum cost, diagnosis of serious mental illness, not in the public mental health system for the prior year, take out people in nursing home, hospice, renal failure. Average cost per year of this group is $50,000. These are $50,000 a year utilizers. Our initial auto enrollment was 1,400 people. We do a new auto enrollment about every 120 days. January 2014, we had about 1,900 in. We've served about 3,600, 3,700 people total since we started in 2011. Here's their burden of disease. Red bar is DM3700, blue bar is healthcare home, and the green bar is the general population. Diabetes, 35%. In outreach, 30% in health home, 8%. This is a Candom hotspot model, going out and looking for the very sick, high utilizers that are not engaged in care, in organized care. They're getting a lot of care, they're just bouncing all over the place. Here are some HEDIS indicators showing improvement in diabetes LDL from 19% measured and under control, currently up to 41%. For blood pressure from 25%, now up to 53%, some nice increases. Asthma actually looked pretty good when we got them. That surprised us. Hypertension, some nice increases, 24% measured and under control, now up to 47%. Similar pattern for LDLs in control for people with cardiovascular disease. These people are heavy. Obesity is a major issue. It's our current push this year is tobacco and obesity. I don't know if we'll move the needle or not, but that's what we're going to take a whack at. Look at the skewing on BMI over 40 compared to the general population. 30% morbid obesity in health homes, 20%, in the outreach, 22%. Just good old-fashioned regular your obesity, running higher numbers also. Weight is a big issue for this population. Tobacco use is higher in this population, and we've not particularly deflected it. Health homes together, if you combine primary care and CMHCs, we've treated 43,000 people at an average per member per month of $70. We've recouped our $70 and saved another $52. Cost savings to the state, $23 million. Better outcomes at a lower cost. DM 3700, just under 3,600 people. Cost decreased by $600 per member per month. Just those 3,600 people saved $22 million. This is what you can do with data targeting. So, health homes. We were the first in the nation to get approved. We were the first in the nation to be statewide with primary care and mental health. Here you see the other that are health homes. The striped ones have health homes, and the ones that are in blue also have state plan amendments, meaning they're doing health homes. It's about a third, and they get a couple more all the time. It is a growth thing. So, change, my inspirational side. We talk about change in healthcare. We all have had change management classes, and my message is change. When the winds of change blow hard enough, the most trivial things can turn into deadly projectiles. So where do you want to be in this picture? You want to be the thing hit by the projectile? Do you want to be the projectile? In the primary care clinics and CMHCs doing health home, our solution is to be the wind. That's where you want to be. You want to be the wind. And you all can be the wind. Get ahead of the change. Be the change. Thank you. I do have two more comments, though. I'm always asked what made this possible. I just came from, where was I? I was out in Connecticut, and they're saying, how did Missouri do this? We have a national reputation for this. And they want to know about data sets and funding levels and IT systems. I say that wasn't how we did it. It was through relationships. What made this possible is a basic trust between Department of Mental Health, MoHealthNet, State Budget Office, Primary Care Association, Hospital Association, transparent use of data, being willing to benchmark each other and see how each other's doing, willingness to take risk, and lots of training. So we've all had disappointing partnerships where we worked on projects, dysfunction. The only consistent failure in all your dissatisfying relationships is you. You know, often when we go about being partners with another organization, we go to them and talk to them about what we need and how we're underfunded and how nobody regards us as much as they should. And we whine about our lousy deal that we've got and how much we need their resources. We do this a lot in mental health, behavioral health care. I've seen it in primary care also. We're unloved, we're underfunded, help me, give me your stuff. This is not a good solution for getting a partner. I actually have done research on this. When I was in college, I would go to drinking establishments and identify potential partners with attractive resources. I would explain how needy I felt and how well their resources could fit those needs. I went home alone a lot. So in mental health, when we wanted to partner with Medicaid, we went to Medicaid and told them they had really interesting problems that we wanted to hear more about. And we found little gifts that could help them out, that we could give them to help them out with their problems. Helping manage the pharmacy benefit, helping manage the therapy benefit. When they got beat up politically, we would stand up and make helpful comments from the crowd or work behind the scenes to get them out of their pain. And now we're good partners. We're so good partners, they even hired me. So I think if you're going to succeed, you need to make being a good partner a strategic goal that your organization pursues consistently. Your goal should not just be to get this or that done. It can be, how can we be seen as the entity that people go to if they want to be successful? That means talking straight, being respectful, showing loyalty, being loyal. Your partner's goals are as important as your goals. Listening first, keeping commitments, confronting reality when needed. So what you don't do when you look for a partner is talk about your need first. You ask your partner about their need. You don't expect to get something. You start out by giving something. You don't limit your assistance to the project at hand. You do assist however you can. You don't make the partnership about this one project or deal. You make it about the next 10. Most of the people we do business with, we will be doing business with for decades. You're not going to get away from MoHealthNet. MoHealthNet's not going to get away from you. We're all going to be here 10 years from now. Don't take a specific position. Talk about your common interests. Don't withhold information. Reveal everything. You can't do a partnership hiding stuff. And most important, when your partner gets in trouble and has to take lumps on the budget or politically or in the press, stand up there with them. Don't leave them hanging there in the wind. If you stand with them when the going's tough, then you'll have a partner next time you need a deal. That's how we got it done. And you know, we're better at that in Missouri than most states. We're better than that than most states. And I want to encourage you to make that a conscious goal so we can continue to beat out the rest of these other suckers around the country, because that's kind of fun. Thank you.
We do have some time for questions.
I have a couple of comments. Thank you. Excellent. I don't live in Missouri, but I'm very proud of the work you've done. First of all, in calling all this health care homes as opposed to what it started out. And I'll admit right up front, I'm a nurse. Very proud to be a nurse. Loved your comments on nursing being the key pin or the foundation of coordinating all this. I do just have to comment on your LPN comment. In general, you get what you pay for. Most of the research, all the research I know of, shows that those relationships that I couldn't agree with you more are key to the success of much of this. You need to be educated how to do that, how to work with people, how to reach where they are, how to be where they are, all the things you talked about. And I love LPNs, I work with them all the time. In general, they don't have that skill set for a continuous. I would just like to suggest that you think about that in your research.
We actually do get what we pay for. When they switch out an LPN for an RN, we ask for 2 LPNs for every RN. It becomes a case mix. Every health home can't have more than 2 LPNs for every RN they have, so we have a minimum ratio. Just like we don't have primary care physicians do everything, we don't have RNs do everything, we don't have LPNs do everything, and we use some community case managers. It is about a multidisciplinary team. So we certainly, all of the health homes have RNs, but we see LPNs as an important member of a multidisciplinary team along with the RNs.
That makes more sense than kind of how you said it earlier.
Yeah, I should explain myself better.
Yeah.
No, we have, they have to have at least 1 RN. They can't have more than 2 LPNs per RN. It's, yeah. Yes, Karen.
So, in the last year, Janet Farmer's leading a big childhood obesity initiative around the university. There's a big childhood obesity meeting. Very interested in how we're going to crack this obesity issue. And we listened to a wonderful professor from St. Louis, and she gave us this great data about how they made big changes in the lives of children. And at the end of it, I asked her, you know, what did it really take? What did this program really take? Well, it took working with the entire family once a week for 52 weeks.
Crazy
That was the
expensive.
intervention, was having a multidisciplinary, remember this, intervention, but it was with the whole family once a week for 52 weeks. Now, I'm interested in your dose, you know, your dose curve and
Yeah.
intervention, the personal relationship. That probably isn't realistic for, you know, for the whole population, right? So
Yeah.
how are we going to, where is it gonna be? Like how much less can you do and still make a difference?
Yeah.
That's a question I have. And
So it was, you know, we had our annual meeting for the physicians in health home and for the community support workers, and there was one track on obesity in each. So, and we funded an additional formal program at about 1/3 of them that is going to cost us about an extra $200,000. It's not near the intensity of what she did, but it's more than we've done before. I don't know, we're going to try and up the intensity some and see if we get any traction. If that doesn't work, we'll try something else. I think it's going to be different for the kids where it's more preventive and different for different level of obesity in the adults. If you got a BMI of 38, losing 10% of your weight ain't going to get it. I think where we're going to focus there is referring more to bariatric surgery. How else are you going to get 50 pounds off them? And the numbers are good. Actually, we ran our numbers on bariatric surgery, and we saved more on bariatric surgery than it cost. It has an ROI of about 4 to 1 in the HealthNet program. I don't think we're doing enough bariatric surgery. Yeah. Question?
So, I'm a nurse care manager here at the university, and I wanted to just make a couple of comments. Transportation has been huge in this. Logisticare now knows when I call them up and say I need to get somebody in the next day, I don't get refusals.
Good for you.
That was in part of what we're doing. Second of all, cyber access has been huge in what we're able to do. Finding out the pharmacies that people are using. I mean, our medical record, that's where we send things.
Isn't cyber fun? Isn't it cool to see what these people are up to?
Yes, because I can tell what they're refilling, how often they're refilling it, and then if I can't get a hold of somebody, I just call the pharmacy and say, my phone number for them is not working. When they come in, I need you to let them know I need to reach them. Huge, huge difference. The other one was the continuity of care within cyber access. So I can tell if they've gone for their eye exam across town with somebody that doesn't bill through the university, but I can see if my diabetics have been to their eye exams. Or I can see if there's another community agency working with them, that I'll say, who else is working with you? And they'll say, nobody. But I'll find out Boone County Family Resources is working with them. Huge difference. And then lastly, I've developed some partnerships outside of the university that I probably wouldn't have otherwise. And that's related to the lock-ins that we could do if we needed to. And there was an open period of time, and I'm hopeful that by us talking, we can open that up again a little more if we need to. It's not a quick process, but I developed a relationship with a social worker at, I'll just say, a different hospital in our community, and I had somebody go into their ER all the time. And so finally, she would call me up from the ER, the social worker, and say, guess who's here? And I could interact with her at that point in time, and I could get a hold of her primary care, and we could figure out what's the follow-up plan before she was out of the ER. It would happen during the week now. There were some breakdowns. But you didn't mention the lock-ins, and that has helped because we have a great electronic medical record here at the university.
Yes.
And it helps us immensely. But if they're outside of our system, sometimes we don't get all of that information. So.
Yeah. Isn't she great? Give her a hand. She gave excellent examples. We are working on revising Logisticare's contract. It'll take a change in their actuarial rates. That'll take us another 6 to 9 months at least. But you raise a very good issue. People go to the ER sometime or use an ambulance because it takes 3 days, and you can get the next day clinic appointment, but you can't get a ride for 2 days, and that really stinks. So there's a problem we got to fix there. I want to thank you for the call out on cyber access. It is very helpful. I think one thing the university needs to do is to join Missouri Health Connection. You can get the same thing off Missouri Health Connection as a CCD. You could get it direct in your power chart. And the university needs to join Missouri Health Connection because you can't get that off your current health information exchange. And that is the statewide HIE. And if you're going to get care from everybody, that's the platform you all need to be on. And you should talk to your administration about that. Yeah.
I represent the business community in St. Louis, and I want to say thank you. There's a lot, I took some good notes. There's a lot that we can learn from what you're doing. And so what I'm curious about is how does the story get out to the public? Because I pay a lot of attention to what's going on in healthcare. I know that there's been a medical home, but this is the first time I've really heard results. But it seems like a really important story that ought to be told in a lot of different ways.
If you have a business community meeting in St. Louis, I'd be happy to present to them. We actually have had a fair amount of press coverage, and I talk about twice a week. We're always trying to get the word out more. Actually, we should talk. I have an opportunity for the St. Louis area to get a comprehensive inventory done of your data situation. We should talk. Yeah. Yeah.
Phenomenal work, and really thrilled that you're part of this is getting into the home. For those people who have aversions or whatever, don't show up other than in the emergency room. I have a question about medication reconciliation. You mentioned it briefly. And for 20 years, I've been saying the gold standard of medication reconciliation happens at the kitchen table.
Yes.
Sometimes get a different story in the clinic or through a phone call. At the kitchen table, they pull out a fruit bowl, 20 filled containers, they traded things with their neighbors and all that. But it seems like you have the data collection, you're doing some medication reconciliation over the phone. You're also having some folks going out into the home. Are you
We've not done a gap analysis between what we see on and what we find in, around the sink, as it were. That's a piece of research we haven't done. I certainly hear anecdotally from our community workers that they're astounded at the 3, 4, 5-year-old bottles floating around and the bottles with 6 different colors and shapes in them. And one of the best risk reduction things you can do is clean out that bowl on the table. Yeah. One of my favorite things to do when I see people at family health centers say, just put it all in a bag and bring it to me. Just bring it, I don't care what it is, bring it all in. Very sobering.
So it seems like these patients who are the high cost are getting kind of this intensive intervention. I wonder if, their friends or family members or whoever are saying, gee, why don't I get that level of care from my doctor, and how would I increase my utilization to be in that group?
Yeah, you raise an excellent point. I have a family member, my daughter, who goes to Boston University, is IV dependent due to a GI situation and has an ostomy bag and gets admitted about 5 times a year and probably costs about $1 million a year for especially TPN or hospitalizations. And when we went to move her to Boston, we called up United Healthcare, the state insurer for UMR, said, can I talk to her care manager? And they said, oh, she doesn't have a care manager. If she doesn't have a care manager, who does have a care manager? It's astounding. We should complain more that more of this stuff doesn't get done. We do need to find a lower level, less intense for people that are less sick. This is an incremental build, and I don't have a level that looks more at preventive care for people that are only episodically ill yet. That's something we're trying to figure out. I think we all should complain more than we do. Yes, ma'am.
I know an RN who's in this program, and she has 250 people that she's trying to follow. Who decides the number of people for one RN? Because she's overwhelmed.
Okay, this has been one thing we've been working with the nurse care managers. It's a new role, and it's more like being a public health nurse than it is like being a clinic nurse. And if she's thinking as if she's a clinic nurse, that she's personally responsible on fixing everything for everyone, she will be overwhelmed. This is more like being either a public health nurse or a utilization review nurse. She doesn't have a traditional nurse-patient relationship with all these people. She's supposed to select a range of people and get that range of people, 20% of them 20% better. This is more like being a public health nurse. I think we'd like to get the ratios down to about 200, but we have had turnover with the nurses that see this as a traditional clinic-nurse relationship. That's not what it is it?
Well, no, it's for the higher risk, what I call higher tier people. You have to have that kind of relationship, so they'll call you. So you want that. But then the other thing is to look at within primary care. One of my greatest assets is my behavioral health people to help me, especially with some of our obesity, some of our tobacco use, and making sure that if they need some mental health, their medical prevails, but maybe if they need some mental health, they have the right resources at the right time. So that part, I don't feel like I have to see them every time. I stop and see them but I don't spend 30, 40, 50, minutes with them. I just spend like 5 or 10 and just say, hey, seems like this is going well. What's not? What can we help with? And then go from there. So,
And I think,
different kind of relationship.
and it is harder for the ones in the primary care health homes because they don't have as many mental health case managers to delegate to. And that is a current shortcoming. We don't have, you'd probably on primary care call them community health workers instead of mental health workers. And that's a staffing thing we need to remediate. Yes, follow-up question.
Now, do you all send information like how to educate the patient on obesity, or is everybody sort of in the dark on how they approach that? Tobacco cessation?
Yeah, we have a range of options available. They're mostly manualized patient education that a person can do a manualized curriculum, either individually or in a small group. So there's a range of different programs we have available. We use a lot of the American Lung Association on smoking. It's not a program. It's a couple of things. So they're not completely supported, but they're not completely unsupported either. Yes?
Is there a mechanism for physicians to refer?
Sure. If they are a MoHealthNet person, you can call up your health home director and say, I got somebody I'd like in. The health homes can propose people to enroll.
I was gonna say, that was the other thing I was gonna say. We propose people who, and we watch for people who've been lost to a system, who maybe moved and
Yeah.
come back. And then you guys are good about sending a potential list that we kind of go through and look at as a team
Yeah.
of, are these, can we enroll these people? So we have some ways within primary care that we're looking at them, for enrollment. My other thing was, I wonder what Medicaid expansion would do to a program like this. Because I think that, again, we're not reaching everybody that we should be.
That's right. Medicaid expansion is the most regrettable lost opportunity for this state. It would save $100 million a year under what we're paying now. It would cover people. It would be an economic stimulus. It's kind of a no-brainer. It's kind of a no-brainer. It would expand this program. It would expand jobs in this community. It would get people care that aren't getting care. And these are relatively cheap people compared to the people that we're covering already. You know? You've been a wonderful audience. Thank you for the questions, and thank you for your work.